Hi everyone and welcome. Today, we'll be delving into the world of dentistry to explore a fascinating, yet enigmatic entity, the odontogenic keratocyst. The epithelial lining of OKCs is derived from the dental lamina and is distinctive for its thin, keratinized epithelium. When the keratin sloughs from the surface of the epithelium, a collection of viscous or cheesy material can be found in the cyst's lumen. In contrast to most cysts, which are thought to enlarge solely by intraluminal osmotic pressure, the epithelium in the OKC appears to have some innate growth potential. Occasionally, bud-like proliferations of epithelium grow from the basal layer of the epithelium into the underlying connective tissue. Also, islands of epithelium in the wall may give rise to satellite microcysts, which can enlarge independently. These differences in the mechanism of growth give the OKC a different radiographic appearance from other cysts. OKCs can develop in association with an unerupted tooth or as solitary entities in bone. OKCs usually cause no symptoms, although mild swelling may occur. Pain may occur with secondary infection. Aspiration of the cavity may reveal a thick, yellow, cheesy material. In contrast to other odontogenic cysts, OKCs have a great propensity for recurrence, possibly because of small satellite cysts or fragments of epithelium left behind after surgical removal. Although odontogenic keratocysts can occur anywhere in the jaws, they most commonly arise in the posterior body of the mandible and mandibular ramus. The epicenter is located superior to the inferior alveolar canal. Occasionally, OKCs may develop in association with the crown of an unerupted or impacted tooth and may be difficult to distinguish from dentigerous cysts. A change to the contour of the follicle coronal to the cement enamel junction in an OKC, where the follicle enlarges smoothly and uniformly from the cement enamel junction, is one way to distinguish this lesion from a dentigerous cyst. In this panoramic image, a large odontogenic keratocyst is associated with the follicle of the displaced mandibular right third molar. Note the change to the contour of the third molar follicle. The contour of the follicle and the change in its size occur coronal to the cement enamel junction of the third molar. OKCs have a well-defined and corticated periphery. The periphery is smooth, but its border may scallop a thick bone cortex. This picture shows a large odontogenic keratocyst occupying most of the right body and ramus of the mandible. Despite the cyst's large size, the buccal and lingual surfaces of the mandible have been expanded only slightly, as can be seen in the occlusal image. This multi-detector computed tomography image shows a lack of expansion of the mandible and the cyst scalloping between the roots of the teeth. The internal structure is most commonly radiolucent. The presence of internal keratin does not increase the radiopacity. In some cases, curved internal septa may be present, giving the lesion a multilocular appearance. An important characteristic of the OKC is its propensity to grow through the bone without significant bone expansion. This tunneling type of growth pattern with minimal expansion occurs throughout the body of the mandible except for the ramus and coronoid process, where considerable expansion may be seen due to the very thin nature of the bone in these locations. This tunneling effect can also be seen within the alveolar process of the maxilla. Adjacent to an airspace such as the nasal fossa or maxillary sinus, OKCs expand in a concentric and hydraulic manner that is more classical for a cyst. As the cyst enlarges, it can reduce the volume of the adjacent airspace. A large odontogenic keratocyst tunneling through the body of the mandible and crossing the midline to involve both the right and left sides. Despite the cyst's very large size, there has been little, if any, buccal or lingual expansion of the bone. Occasionally, the bone expansion created by large lesions may exceed the ability of the periosteum to form new bone to accommodate the OKC, and the epithelium may contact soft tissue adjacent to the outer surface of the mandible. The relatively slight expansion common to these lesions potentially contributes to their late detection, which occasionally allows them to reach a large size. The inferior alveolar nerve canal may be displaced inferiorly. OKCs occasionally displace teeth and resorb tooth roots, but to a lesser degree than dentigerous cysts. When an OKC develops in a pericornal position, it may be indistinguishable from a dentigerous cyst. The lesion is likely to be an OKC if the cyst periphery is associated with the tooth at a point apical or coronal to the cement enamel junction, or if little or no expansion of the bone has occurred. The scalloped margin or a multilocular appearance of an OKC may resemble an ameloblastoma, but the latter has a greater propensity to expand bone. Occasionally, large lateral periodontal cysts, especially in the maxilla, have a growth pattern similar to that of an OKC with minimal bone expansion. The mild expansion and multilocular appearance of the odontogenic myxoma may make it indistinguishable from an OKC. A simple bone cyst often has a scalloped border and minimal bone expansion, similar to an OKC. However, the margins of an SBC usually are more delicate and often difficult to detect, and there is little or no effect on the teeth or the supporting structures. If an OKC is suspected, referral to an oral and maxillofacial radiologist for a complete radiologic examination is advisable. If, on plain imaging, a cortical perforation is detected, MDCT should be used to investigate the possibility of soft tissue extension. Otherwise, CBCT can be ordered. Because this entity has a propensity to recur, an accurate determination of the extent and location of any cortical perforations with soft tissue extension is best achieved with MDCT. Surgical treatment may vary and can include resection, curettage, or marsupialization to reduce the size of large lesions before surgical excision. More attention is usually devoted to complete removal of the cystic walls so as to reduce the chance of recurrence. After surgical treatment, it is important to re-examine the patient at regular intervals to detect any recurrence. Recurrent lesions usually develop within the first 5 years but may occur as much as 10 years later. If you enjoyed this video, be sure to like and subscribe for more. Thank you.